Thank you. Yes, then I would love to move on to the current therapies for metastatic TNBC.
Absolutely. So, in contrast to early stage triple negative breast cancer, the approach to metastatic triple negative breast cancer is very much driven by certain biomarkers. So, one question you absolutely want to have an answer to is hereditary genetic testing and whether you carry a mutation in BRCA1 or BRCA2. This is obviously has implications for risk of developing a breast cancer and has implications for family, but it also is a biomarker today that allows your doctors to choose therapies like PARP inhibitors, medicines like olaparib or talazoparib, that are FDA approved only in women who have germline BRCA1 or BRCA2 mutations. So question number one, do I have a BRCA1 or 2 mutation? The other important biomarker that is standard of care that you need to know in metastatic triple negative breast cancer is whether the tumor tests positive for something called PDL1. So PDL1 is a predictive marker as to whether immunotherapy will work or not in metastatic triple negative breast cancer. And for tumors that are PDL1 positive, the first choice as first-line therapy for metastatic disease would be using immunotherapy called pembrolizumab with chemotherapy. And that chemotherapy could either be a taxane or commonly platinum-based chemotherapy like carboplatin with gemcitabine. So if PDL1 positive tumor, you want to be leading with immunotherapy plus chemo. And that's because long-term outcomes are better. It is superior to get that immunotherapy. If women's tumors, I should say, lack PDL1, then the first line chemotherapy standard of care is generally either a taxane or a platinum, or sometimes there's even a place for the chemotherapy pill Xeloda or capecitabine that is still commonly used. If women have a BRCA mutation and their tumor is PDL1 negative, then rather than chemotherapy, that's where we would prefer to use a PARP inhibitor. Those medicines, olaparib or talazoparib, are pills, very well tolerated, work better than chemotherapy. And so it really allows a woman to maintain high quality of life and have superior treatment without having to be hooked up to intravenous therapy, have hair loss, have all of the other complications that come with systemic traditional chemotherapy. So that is sort of the basic approach to the very first treatment patients will get in the first line setting. I'll always put a plug in for even clinical trials in that setting because we're consistently pushing the envelope. When we find drugs that work in later line setting, we want to move them up earlier. We want to give women the opportunity to get these highly active drugs even sooner and test to see if they're better than our current standard of care. Once we get into the second line setting, so you've been on that first treatment for many months, hopefully even longer, maybe we're talking about over a year, but something has changed on a scan that warrants a change of therapy, or there's sometimes a side effect that develops that just makes a treatment no longer tolerable or safe to use, and we're at a decision about what to use next. This is a place where I would really urge, again, to be sure your doctors are looking for a mutation profile for the tumor itself. So rather than hereditary mutations, which are in every cell of the body, like BRCA1 or 2, we want the tumor itself to be sequenced and find out what genes have been mutated or turned on that might explain the biology of the cancer a little bit better. Sometimes those mutations then create a vulnerability in the cancer that we can find targeted therapies to match that would have a good clinical rationale for why a drug might be helpful in that setting. So you want to sequence the tumor to see if that helps guide next line therapy. You also want to ask your doctor to be a little bit more precise than just saying triple negative. You want to know exactly how the HER2 protein is defined. This is very important today because there are now targeted therapies to HER2, even if you don't technically have HER2 positive breast cancer. So HER2 is scored on a scale of 0 to 3. 0 is definitely negative. 3 is definitely positive. But HER2-1 or HER2-2 plus are now defined as HER2-low. And if you have hormone receptor negative HER2-low breast cancer, this is now a space where there's a targeted therapy that's highly active called Enhertu or trastuzumab deruxtecan. So you want to know that biomarker, exactly what is your HER2 status, what are the other mutations in the tumor, because that will all help guide that second line standard of care treatment choice.
Okay, thank you.